Welcome everybody to this webinar. We're going to be speaking for the next hour or so about about GRADE, and this is part of the Academic Emergency Medicine GRACE project, the guideline development for Society for Academic Emergency Medicine. I'm really happy to be able to introduce Hassan Murad. He's a professor of medicine at Mayo Clinic, Rochester, an expert in public health and general preventive medicine specialist. He's director of Mayo's evidence-based practice research program, and in that role, one of his jobs is helping to create systematic reviews for dozens of organizations, including the World Health Organization, the American Society of Hematology, CDC, and NHLBI, among many others. Pertinent to today's topic, he is a great expert who led the workshop that Sunil, Fernanda, and I attended in Orlando back in September of 2019, and graciously offered to provide us an hour of his time to do a crash course into what is GRADE for this guideline entity that we're starting to contemplate at SAM. I'm going to ask everybody to keep your audio on mute while Hassan speaks for the next 50 minutes or so, and Hassan's going to give us some time for questions at the end, so we'll save the questions for the end. Hassan, welcome.
Great, thank you, Chris, for the double introduction, and it's a pleasure to speak to all of you this morning. My outline will include an introduction to guidelines, where I will talk about what makes a guideline trustworthy, and I will entertain the question of whether guidelines actually improve outcomes or not. And then I will give you an introduction to GRADE and how we evolved into GRADE. So looking at criteria from GRADE, from the Institute of Medicine, from the Guideline International Network and others, a trustworthy guideline is a guideline that's based on a systematic review, so evidence is not cherry-picked for a guideline. A guideline should include some sort of a grading of how certain we are about the evidence, and then it should provide a strength of the recommendations so that people who are implementing the recommendations know how compelling the recommendation is, and whether it should apply to everyone or not, and whether they should do quality improvement projects based on it or not. And the guideline should incorporate patients' values and preferences. There are other criteria that relate to managing conflict of interest and plenty of other criteria. But the key ones is that you have the systematic review component, and then you need to grade the certainty in evidence and provide a strength of recommendation. The question is, do guidelines improve outcomes? And I ask this question in workshops, and many people say no, or they're not sure. And actually, there's a lot of research that showed that adherence to guidelines improves outcomes. There are studies in heart failure, in breast cancer, in pneumonia, atrial fibrillation, and many others. But these studies are designed in a way where they compare two groups of patients, a group that received guideline adherent treatment versus a group that received a treatment that did not adhere to guidelines. And there's clear difference in outcomes, particularly in mortality and cost, and other patient important outcomes. So I think the message from this is that numerous examples document better outcomes with guideline adherence. However, we acknowledge that adherence to guideline is low, and adherence may be lower in certain groups. So there's research to say that women may get less guideline adherent treatments. There are some discrepancies based also on age, so older people may not. Some ethnic and racial differences and others. So we need to do a better job in implementing guidelines, but we think that guidelines at this point will improve outcomes. Passive diffusion of guidelines does not work very well. So if a society comes up with guidelines, that does not mean at all that people are going to adopt these guidelines. And we need to have this second effort and second branch of research, which is healthcare delivery research and quality improvement and all that, to make sure that guidelines are adhered to. So just putting them out does not mean people will follow them. The evolution of guidelines in the 70s, there was the NIH program that started developing consensus statements. Now, this was a very good thing for medicine. Experts convened and they recommended management approaches based on their own practice, based on what they have seen and used in their practice. They sometimes cited references that they recalled, sometimes they didn't. It was an unsystematic process. And this NIH consensus development program was a success. It was a good thing. So this was a good thing for medicine. But we evolved from that, particularly in the late 80s, where the concept of evidence-based medicine became the way for making decisions. The term was coined by Gordon Guyatt in the 80s, and then there was their infamous workshop that started in 1991. And this year in June, it will be their last workshop. So they ran the workshop for 30 years or so, and now they think that people, that this became a no-brainer, that they don't need to do these workshops anymore. So that came about. So that was one factor. And the other factor is more evidence has become available. So there's more research. It's accumulating over time. So having more research, having the EBM principle led to further evolution of guidelines. And then guidelines started citing empirical evidence, started citing research. So the next generation of guidelines started reviewing the evidence, whether a systematic or an unsystematic review, but it started to review the evidence and started basing their recommendations on study design label. So the concept of the pyramid came about from the EBM movement, where randomized trials are on top and systematic reviews and meta-analysis on the very top. And based on that, they start, there was a clear dichotomy where randomized trials will lead to high-level recommendations and non-randomized studies will lead to a lower-level recommendation. This was an improvement compared to the NIH consensus program, despite some issues with it, but it was an improvement. And the American Heart Association is a framework you may be familiar with, is based on that, where the study design label drives the recommendation. So for example, level A, it says data driven from multiple randomized clinical trials or meta-analysis. So if you have this label, RCT or meta-analysis, you have a higher level recommendation. The challenges with this design is that, or with this framework, is that study design does not necessarily equate to risk of bias. So the design label does not necessarily tell us how trustworthy a study is. And there are other factors beside the bias and the study design that are important for decision making. There are many other factors. So this pyramid framework is now less likely to be representative of the current paradigm, because within just one category of a study design label, like randomized trials, we know that there's a range of how trustworthy these studies are. So the ones with blinding and high level of follow-up will be higher, will provide higher certainty or lower risk of bias. And then there are grades. So maybe a lower level will be ones that are blinded, but they don't have as good of follow-up, and so forth. The same for the observational studies. So the pyramid design doesn't really reflect this newer paradigm. So what we proposed is to modify this pyramid in two ways. So first of all, within every strata, that these straight lines didn't make very sense to us, and having the systematic reviews and meta-analysis on top also did not make sense, because some systematic reviews may summarize case series or case reports or lower quality studies. So it really didn't work very well. So we proposed two modifications for this pyramid, where the first one, we make these lines wavy, which implies that you have various levels within every design, and to chop off the head of the pyramid, because that's not really a primary study design, and instead use this systematic review and meta-analysis tool as a lens to appraise and utilize the evidence. So we have the wavy lines and the lens. This is just a cartoon to present the three principles of evidence-based medicine. This is the current thinking, is that there's a hierarchy of evidence. Not all evidence is the same. So there's some sort of a pyramid type of thing, but not clearly a pyramid. And also that decisions should be based on a body of evidence, so not individual studies. So a systematic review, basically. And the third principle is that evidence alone is insufficient for decision making. So there are these other factors beyond evidence. All of this leads into GRADE because GRADE is really based on these three evidence-based medicine principles. So it's a working group of clinicians, methodologists, and researchers and other stakeholders and policymakers that formed in the early 2000s and came up with GRADE, this is what it stands for: grading of recommendations, assessments, development, and evaluation. So it's a system in which you develop the recommendations and you evaluate them as well. And the aim is to have a rigorous, transparent, and practical system, and also a unified system, because there were so many systems that it was confusing to stakeholders. I think at some point there was a systematic review that showed maybe like 50 or 60 different systems at a given time. So GRADE in a nutshell has two components. One is to determine certainty in the evidence, how certain you are about the evidence. And the second one is to come up with a recommendation that can be a strong or a weak recommendation. So it has these two components. I will run through these two components and their domains. This is what our workshops are targeting. So there are a lot of GRADE workshops. The US GRADE network puts out workshops twice a year that are 3 days long, and they include hands-on, small group work. And the focus is on these two components: how to determine certainty in evidence and how to come up with a recommendation. So let's talk about the first one: certainty in what? So what does that mean when we say certainty in evidence? If you think about a situation where you have several studies and then you have a summary of these three studies combined. Now, I use here a forest plot to imply that we did a meta-analysis for these three studies, but sometimes you cannot do a meta-analysis. It may not be appropriate, or you just cannot do it. But still, we're talking about the same thing. We're talking about the whole body of evidence as it relates to a particular intervention and a particular outcome. So we are talking about certainty about a pooled estimate. We're not talking about certainty of one study. So you cannot grade every study. We're grading all the studies as they relate to an outcome, reflecting how certain we are about the outcome. So how trustworthy is this estimate? This can be in a non-contextualized view where you are talking about just numbers. So this odds ratio of 0.7 with this confidence interval, how certain am I about this estimate? It could be also contextualized further. So we can say, how confident am I about this, or how certain am I about this estimate to warrant an action, to deliver a medication, or to provide an intervention. So we can have different levels of contextualization, but the bottom line is the certainty means how trustworthy this estimate is about the outcome. And this estimate comes from multiple studies. So GRADE is outcome centric. So we have multiple studies, we have multiple papers, and each one is going to inform us about an outcome. And then we have some level of quality or certainty or trust in that outcome. This is a framework of GRADE. Basically, we start with a preliminary level of certainty based on study design. So we know that randomized trials warrant higher level of certainty than observational studies. And then we modify this level by using multiple factors. Some factors will lower our certainty and some will raise our certainty. I will explain these in one slide each here in a minute, but there are factors that lower or increase certainty and will modify this original level of certainty that was based on study design. And that will lead us to reach a final level of certainty in the evidence. And this will be the first part of grade, is to say how certain we are about a particular outcome. So there are five things that will lower your certainty and 3 things that will raise your certainty. So there are 8 domains. I will run quickly through these domains just to give you a flavor of what they are. So the first one is study limitations, which is also called risk of bias. These are very intuitive to people. It's about how bad a study is, right? How bad is a study design? So it's per study, per outcome, and then we can make a judgment across all studies because we want to grade across all the studies. There are different tools to look at different study designs. So for a randomized trial, there's like the Cochrane risk of bias tool. For observational study, there are tools. For diagnostic studies, there are tools. But study limitation refers to the very intuitive thing that when you read a study, you say, oh, this is poorly done. That's the risk of bias. There are formal ways to evaluate it, but that's basically what it is. The second thing that will lower our certainty is inconsistency or heterogeneity, which means there are different results between individual studies. So if you have 5 studies and they're giving you different results, you're less certain because they're inconsistent with each other. The causes for that could be differences in the studies, different patients, different interventions, different outcomes. Could be differences in the method or the risk of bias. So maybe some study is a bad study, some study is a well-done study. And that's why the results are different. It could be due to chance as well. And sometimes we propose hypotheses to explain this consistency. So we'll say, maybe this study is showing different results because the patients were older. And maybe this study is giving different results because the patients are sicker. These are called subgroup analyses or regression analyses that are done to explain differences in results between studies. And if you explain the differences, then you're not uncertain. So the uncertainty is when you cannot explain differences. You probably have seen common visual presentation of inconsistency in forest plots. And in forest plots, you can look at them with your eyeball. We call it the eyeball test, where you see variation in the point estimates and the effect sizes between the studies. So in a forest plot, you see the dots that represent the effects of different studies are different from each other, separated. Or you see the confidence intervals do not overlap. So this is just by looking at the forest plot and determining how much inconsistency there is. If you don't have a forest plot, you can look at that. You just need to do that qualitatively or narratively. There are statistical tests, of course, as well, like tau squared, chi-squared, and I-squared. And these are just statistical tests to tell you how different the results are between different studies. So for example, the I-square, which is the one that's mostly used these days, is a simple percentage. So it tells you the percentage of heterogeneity that is not attributable to chance, and it reflects really differences between studies, as opposed to differences in individuals within the study. So it's differences between the studies. So this is the second domain, or the second reason that will make you less certain about a result. The third one is imprecision, and imprecision refers to when you have a small sample size, low event rate, and that will lead you to have very wide confidence intervals. So we've encountered this particularly in small studies, and you will rate down because your decision might be different if the truth was one boundary of the confidence interval versus another boundary. A variation of this is the p-value, right? So if you have a small study, you have wide confidence intervals, your p-value will not be statistically significant. So that is a form of imprecision. But in grade, we don't really use p-values at all, because even if you have results that are not statistically significant based on this arbitrary cutoff point of 5% of a p-value, you have a confidence interval upon which you can act. So the confidence interval may go from very little harm to a lot of benefit. So most of the confidence interval suggests benefit. So in that case, you may recommend something despite the fact that it's not statistically significant, because the p-value of 5% as a cutoff is very arbitrary. But that's imprecision. It's small number of studies, small studies, low event rates, and that leads to very wide confidence intervals that makes you uncertain. So it's another reason why you would be uncertain or less certain. And this is an example of a visual depiction of imprecision. So let's say we are delivering a treatment for stroke, and we say we're going to deliver this treatment if we have 2% reduction in mortality. Say it's some sort of a TPA or something like that. If the benefit was less than 2%, we wouldn't give the treatment because we will have side effects. So if this was the results, then we are certain and we are precise because the point estimate and its confidence interval all suggest benefit better than 2% reduction in mortality. So here we would not downgrade. On the other hand, if the effect was like this, then we are less certain here about the benefit, and we are less certain about making a recommendation because this upper boundary of the confidence interval of the pooled estimate suggests benefit less than 2%. It's still statistically significant, right? Because it doesn't cross the null, but it is below a threshold upon which we said we are going to make an action. So here we would be less certain and we would rate down the certainty in evidence. All right, the fourth reason for being uncertain or less certain is indirectness of evidence. So what does that mean? So we know the PICO question of our recommendation, the PICO patient intervention comparison outcome. So that's the PICO we developed when we started our guideline process. We said we're interested in this question. However, when we went and did the systematic review, we found something different, right? We found maybe we didn't find any of the studies that fit our PICO, or found studies that somewhat fit our PICO. So the PICO of the guideline is different from the PICO of the evidence. That's called indirectness. It could be due to the P in the PICO, the patient. So it could be that we're interested in young people, but the research is on old people. It could be the I, the intervention. So maybe we're interested in intravenous medicine, whereas the literature was about an oral medicine. It could be the O, the outcome. So maybe we're interested in diabetes mortality, but the literature is about lab tests. It's about surrogate outcomes. It could be an issue of long follow-up that we desire, but the research is giving us short follow-up. So the differences between our PICO for the guideline and the PICO of the available evidence, that refers to indirectness, and there's indirectness. If it's sufficient indirectness, then we're less certain. So it's a simple depiction here of the two PICOs, and it's our judgment whether they are similar. The patient, the one that we are going to make a guideline about, and the research. And then the last reason for being less certain is publication bias. That's the fifth and last reason. So this publication bias refers to the fact that faster publication occurs when you have positive trials, positive meaning statistically significant trials. We've all suffered when we have a negative trial about how to publish. It takes longer time, and sometimes it's published in lower impact journals or never published. So systematic reviewers need to search the gray literature, meaning Google and some other resources, to find these unpublished studies. And so how common? It's pretty common. Actually, about maybe 20 to 30% of trials submitted to the FDA are never published. So if you are a pharmaceutical company doing research on a new drug, let's say you conducted 14 trials, you have to submit all 14 trials to the FDA. You have to. But then you can publish whichever one you want. You may decide not to publish any. You may decide to publish 3 out of the 14. And the ones you decide to publish, well, guess what? Which one are you going to publish? You're going to publish the ones that are most impressive or show larger effect or show significant results. It's not a random. It's not like you're picking the ones you're going to publish at random. So this leads to the whole literature being inflated, and anything we see published is actually, we're seeing the things that work, and we don't see the things that do not work because they're not published. In some extreme examples, 75% of data are unpublished. It is not at random. Published data tend to overestimate benefit and underestimate harms. There's tons of research about that. And how to detect that, you can do this gray literature search by looking at registries, protocols, FDA records, Google, so forth. And there are some statistical methods, but they're not very good. But there are some statistical methods that when we do meta-analysis, we can find a signal of publication bias. Very good. So I talked about the framework. I talked about these 5 factors that lower certainty. Now I'm going to talk about 3 factors that can increase certainty. So it's a more uplifting conversation. So let's look at this scenario. Total hip replacement for people with disabling hip arthritis. There are no randomized trials that compared having a replacement to no replacement. You can imagine how difficult it will be to do a randomized trial on that. However, we are extremely certain that the total hip replacement helps in reducing osteoarthritis pain and disability. And we say that because we see the improvement immediately in front of us. So why is that? Actually, it is because of this large effect, because we see a large effect in improvement. And there's modeling evidence and empirical evidence that suggests that confounding is unlikely to explain an association when the effect is large or very large. So large was a relative risk of more than 2, or the reciprocal of that is 0.5, meaning the intervention doubles the benefit or halves the harm. And then very large with a relative risk of 5, and the reciprocal is 0.2. This refers primarily to observational studies. So if you have an observational study with a very large effect, and you say, well, this observational study has confounding, has bias, because it's not randomized, but we don't think if the effect is large, is that this bias can explain all this large effect. So it may explain some of it, but not all of it. So in GRADE, you can increase certainty in observational studies when you have a large effect, particularly if the trajectory of this effect is fast, like you can see it happening quickly and changing the trajectory of the disease. There are many examples that you can look up for that. The second scenario in which you raise your certainty is when you see a dose effect gradient. So the example here is about how fast you give antibiotics in septic shock, so that the faster you give it, the more survival patients have. This will tell you that this association is probably true and you have higher certainty in it, despite the fact that it came from non-randomized studies. So that's the idea here, is that this is not from a randomized study, this is from an observational study, but because you see this phenomenon, you are more certain about the association. The third one is the least intuitive one. It's a little difficult to explain, but I'll give you this example. So there are well-done observational studies that showed no association between autism and vaccination. Now, these studies are biased, right? Because they're observational studies. And the main bias in them is recall bias. So parents of children with autism are more likely to remember that their child started having symptoms after vaccination. That's called recall bias. But if you actually think about it, this bias is strengthening your conclusions, right? Because you're saying there's no association between autism and vaccination despite this bias. So this bias, actually, the direction of bias will make you more certain about the association. So I call this the despite bias, that you're seeing something despite this bias, and then therefore you are more certain about the association. Another example about this is um, the fact that patients who go to non-for-profit hospitals have lower mortality. So if you observe that in a study, it has been observed in a specific setting in a study, and we know that patients who go to non-for-profit hospitals are usually sicker and of lower socioeconomic class, and they're expected to have worse prognosis, but yet they did better in that study. That will make you more certain about the effect of the hospital status on mortality. So that's the despite bias. Um, Very good. So that is the despite bias. So this was the whole framework I presented. I presented in black and white. Now it's in color. So uh, in grade, we start with a certain level of certainty that's based on the study design. We have things that lower this certainty. We have things that raise the certainty. And at the end of the day, we reach a certain level of certainty. So um, this will lead us to saying that the certainty is either high, which means unlikely that future research will change things, could be moderate, low, or very low. So in grade, we have 4 levels of certainty: high, moderate, low, and very low. And they're determined based on that framework. All right, so that was all the first part of grade. It's just saying how certain we are about an estimate, an effect of an intervention on an outcome. Now we move into the second part, which is making a decision, which is called evidence to a decision, or ETD. So it is the second part of grade. It's a framework for decision making. If you've gone through the workshop, you will see that in small group, we will test this framework and go from one step to the other, trying to make a decision based on the evidence that's given to us. So what are the factors that will make you make a decision? Number one is certainty of the evidence. So everything we've been talking about so far. But then there is balance between benefit and harms. And this has nothing to do with the evidence, really. This has to do with how much we value the benefits and harms, patients' values and preferences, and then the resources and cost and utilization and these factors. So these were the 4 original factors. And then 3 more were added. And these 3 are about acceptability. So is the intervention acceptable? Feasibility, is it feasible to implement in practice? And equity, so whether the intervention or the recommendation that we're going to make will lead to certain health disparities or inequities for certain group of patients. So these 7 factors are built in a software called Grade Pro, and the software facilitates the 2 parts of grade, where you rate the certainty and evidence, and you make judgments about all these domains that raise certainty and lower certainty, and then you move into these 7 factors and make a judgment about them, and then eventually you come up with a strong recommendation or conditional recommendation. These judgments are visually depicted in a way like this, where like we talked about, values, certainty, cost, equity. So when you make every judgment, you go through questions and you make every judgment, and then the results are displayed this way, where it shows where your judgments lie, whether it's on the right side, where you would favor the intervention, or the left side where you will favor the comparison or the alternative course of action. This is just a visual format of it. It doesn't really make the decision for you. It's just it facilitates the process, streamlines the process, and then document the process. It doesn't really make the decision. So it's again, it's at the end, it's a judgment and consensus of the group making the guideline, but it becomes very explicit now, because maybe you did not recommend something because it was extremely expensive, right? And um, and then 5 years from now, a new guideline comes up, and people cannot criticize you, so they cannot say, "Oh, you made the wrong recommendation," because they're going to go and see you made the recommendation because of cost. So it's explained, and that's really the primary, in my opinion, the primary difference between GRADE and all other systems. Because in all other systems, you just make people sit around the table and come up with something, and they come up with a judgment, and there's no transparency or clarity of what drove this judgment. Here it is explained, and you can say, well, we made it because of our concern about cost. If you don't agree about that, well, you can take a different course of action. So the transparency really is the key here. And we come up with strong or conditional recommendation, and they have different implications for the population. A strong recommendations basically means everyone should get it. Healthcare workers, they should all offer it. And for a policymaker, this should be policy or quality improvement project or pay for performance or whatever the context is. But this is a strong recommendation that should apply to almost everyone. On the other hand, a conditional recommendation or a weak recommendation, it has different implications. So for a population, it means most of the patients should get the intervention, but some may not, and it's appropriate that they don't. And for healthcare workers, they need to present options here. So here, this is not just to go and deliver the intervention to everyone, like aspirin after an MI. This is not aspirin after MI. This is where you have to use a decision aid or engage the patient and have a discussion. And for policymakers, this is not a place where they need to make policy and make quality improvement projects. There has been in the past quality improvement projects that were driven by weak recommendations, and they led to patient demise, unfortunately. So maybe 10 years ago or 15 years ago, everyone started getting beta blockers preoperatively for non-cardiac surgery. There was one trial that showed extreme benefit. The trial eventually was withdrawn, and but there were tons of QI projects that enforced that policy. If people have used GRADE at the time, they would have realized that that was a low quality evidence or low certainty evidence, and any recommendation should have been a conditional recommendation and should not be a quality improvement topic. So getting here towards the end, so the process, as you may have guessed, would look like something like this. So there will be the guideline panel will come up with a question that they think will lead to a recommendation. So the question here is, should adults with sickle cell anemia who have 3 or more moderate to severe pain crises be treated with hydroxyurea? So they come up with a question. This question will undergo a systematic review. The systematic review could be new or old. So, and that's where the cost is, right? So GRADE is free, right? It's free. But the cost of a guideline comes from the systematic review, from the lengthy process that can take months to summarize the evidence. Sometimes there are existing systematic reviews that are well done, and you can leverage those and use those. But the question will go from a question to a systematic review into a recommendation. And this is another picture of kind of the whole thing, where you have a PICO, you have a question, you go through the systematic review, you assess across studies, you get the estimates for each outcome, and you grade the certainty in the outcome, use the domains that lower certainty, the domains that raise certainty, Then you come up with the evidence to decision framework, where the panel here in the middle, so that everything is centered around the panel. They will use these factors of the framework to come up with a recommendation, either strong or weak recommendation. So since then, grade has been adopted for more than 100, maybe between 100 and 200 organizations. Actually, I would say very few organizations now are left. I know the task force, the U.S. Preventive Services Task Force, actually uses grade, but they don't call it grade. And then maybe the American Heart Association still use their system. But in general, everyone has moved to grade. There are, a lot of contributors, and that's an interesting point, because if you look at research on guidelines, I would say about 100% of it in the last 15 years has been about grade. I have not seen a paper about guidelines that is not from grade or a grade methodologies, and that's just because of the large methodologies that have moved to that system. Um, like I said, this grade is free. There are free meetings 1 to 3 times a year. Now, these are the actual grade meeting, not training workshops. These are where people go to hear about the latest in grade and developments in grade. Because grade continues to evolve, and they move to diagnosis, to prognosis, to economic analysis, to animal studies, to all kinds of things. So there are a lot of working groups that move grade into different methodologic arenas. If you want to learn more, there's a series in BMJ that's from the that's probably between 2006 and 2008. And then there's the new one from Journal of Clinical Epidemiology, and there's about 25 articles now addressing different components. So like there will be one about inconsistency, one about indirectness. The BMJ articles, although they are old and outdated, but they're very easy to read, whereas the JCE ones are more technical ones. So is there evidence that grade is better than another line system, another guideline system? I really don't care to answer this question, because I think that's not the point really. First of all, there aren't really many systems that are left. And secondly, the issue of transparency. So if you look at any other system before or after, I don't think they're after, but any other system before, they are implicit. So you can never say, you read a guideline, you can never tell why a recommendation was made, because there's no framework. So the transparency, I think, is the key question, as opposed to whether a system is better than another system. That should be the focus. And the other focus is reliability and reproducibility, meaning if I take the same evidence and convene my panel and come up with a recommendation, and you do the same, our recommendations should be similar, because we're following a system that's transparent and has a framework. We're not just making a judgment, a global judgment, saying, yes, let's do this. So in my opinion, the answer to this question about is grade better or should you use grade is really not about anything except transparency and the issue of reliability and reproducibility, going back to having framework. This is just an example of when we used the AHA system and grade, and we looked at the hyperbaric oxygen indications. So there are 16 indications for hyperbaric oxygen that are approved by their society, and they used AHA. So they labeled the study, the evidence as category A or B or C. And then we went and, so what we did is we went and we looked at A, and we found that A actually had very low, moderate, and high certainty or quality. And the same with B. And even in C, we found it to be very high. So there was one indication for hyperbaric oxygen, which is diving injuries and decompression illness, where they rated it as C. C because, in the AHA system, C means just case reports and case series. We thought that's the highest level of evidence, and we rated it as high because of the large effect and the immediate effect. So this is just to show that there is more granularity and transparency, and I would argue reproducibility as well. And that was it. So in what we talked about today was we talked about what makes first about guidelines in general, what makes a guideline trustworthy, and then we discussed whether guidelines improve outcomes, and I think the answer to that at this point is that yes. Then we talked about grade, and we said that grade has two components. The first one is how to judge certainty in the evidence and go up and down on that. And then the evidence to decision framework and making the recommendations. So this is it, and I'm happy to take questions.
Thank you, Hassan. I'm going to ask we've got a few guests from ACEP's Clinical Policy Committee on the line as well. I'm going to ask the AEM Grace folks on the line if you have questions for Hassan first, and then we'll let the ACEP folks ask questions if they have any.
I see Amy Kaji has thrown out a question to the group in the chat. I don't know if we want to start with that one. I also have another question after that regarding the indirectness.
Okay, the question is there a cost to using the Grade Pro software if we're using it as an organization like ACEP or SAM? Is there a fee for that?
Yeah, so the software has been free from 2004 until I would say this year, earlier this year. And this year, the software remains free for individuals that will use the functions that I talked about. So if the function where you rate the certainty in the evidence and produce these evidence tables, that's free. The function where you do the evidence to decision framework and look at the domains and come up with that, that's all free. There are some paid functions for managing a guideline. So you can send, for example, surveys from the software to your panelists and ask them to rate the importance of the outcomes or make judgments, for example, about these decisional factors like resources, values, and preferences. So you get questionnaires about whether there is important variation in patient values or not. So you can survey the group and get and then get the answers within the software. So there are some things that they have developed further, and these do have cost. I think the cost is minimal, but I'm not aware of the cost because I don't really use it for that, and I don't necessarily want to advertise it. But the function that I talked about are free.
Great, thank you. Mark, you want
to? Yeah. First of all, thanks for the great talk. Learned a lot. I am curious if you have any advice for us who are going to be writing this guideline for for patients with recurrent low-risk chest pain. My understanding is that after a very thorough search of the literature, there aren't that many studies looking at that particular population of patients. So we're going to most likely run into issues with indirectness. And do you have any, and Chris, correct me if I'm wrong on any of that, but I was wondering if you have any advice when you're dealing with a situation where almost all the papers and possibly literally all of the papers are dealing with a population that's actually different than the one of interest, and you have a lot of indirectness.
Yeah, your question is going to have a lot of indirectness, and you need to extrapolate. So indirectness means extrapolating. So you need to look at other evidence. So for example, when do you get another troponin? Well, you want to look at literature for about the pharmacokinetics and or not the pharmacokinetics, but like the kinetics of troponin, when it goes up and when it goes down, how long it lasts. You want to look at studies in which patients were low risk patients and admitted and what their outcomes were with various like maybe observational studies as opposed to comparative prospective studies. So you need to extrapolate, and to extrapolate, you need, number one, you need expertise. So you need topic expertise. So I think you want to have people with cardiology expertise, people, various, I don't know, maybe radiology, if you are using any stress tests or anything that relates to radiology. So you need a lot of expertise to find out this evidence, because it's very difficult for you to find it as an emergency physician. You're not familiar with that literature, and this literature can span multiple specialties. So I would bring all that in. So maybe break your question into sub questions that each one of them can be informed by indirect evidence.
Okay, sounds
And
good.
I think this discussion will be is a case by case, on a case basis. Like we'd have to look at the question and see how can we, now that we know we don't have studies that answer this specific question, let's reframe it into several other questions that will lead us to make a recommendation about this issue. Like we're still gonna make a recommendation about our original PICO, but the evidence now is going to be derived from other sources.
Mm-hmm. Right. Okay. So just a lot of extrapolation and leveraging clinical expertise within the writing group.
And transparency, right? So you're gonna start everything, the first sentence in your manuscript is gonna be that we didn't find any studies, and therefore, based on that, we did this, and we acknowledge that our certainty is low and our recommendation is a conditional recommendation. It's all about transparency.
Hassan, there's a question from Jeff Klein that in your Mayo paper, you noted that patient involvement is often token. What are the key steps to gain valuable patient involvement in your experience?
That's a great question. So people bring a patient, put them on a panel. The patient doesn't know why they're there. They're shy. They cannot speak in front of experts, and it's a checkbox, right? So you put a patient, just do a checkbox. So the patients need to be trained. There need to be a lot of safeguards to allow patients to speak freely. It has been done in different ways. So some people will look for patients' values through the literature. So there will be published qualitative research on patients with chest pain and their anxiety and their values and so forth. So you can get it from the literature. You can have a group of patients on your panel. So bring 2 or 3 patients, and these patients need to be trained and activated, right, and engaged in a unique way to get their input. You can sometimes reach out to patient advocacy groups. So societies usually have patients who are experienced in engaging with researchers and guideline developers. So these patients will have the advantage of being able to speak and advocate. They may not be representative of the typical patient, so that's a downside. But these are the 3 strategies that are most commonly used: is literature, which can include surveys and qualitative research. It could be having actual patients on your panel, or it could be patient advocates.
Great.
That's very helpful.
Any other questions from the GRACE folks from Academic Emergency Medicine? Otherwise, the ACEP Clinical Policy Committee members, we'll end just a couple minutes late. We'll go to maybe 10:05 Central Time. Any questions from the ACEP Clinical Policy Committee? Okay, hearing none, unless somebody's on mute. One question I had is, Hassan, one of the things that we wanted to consider with the GRACE guidelines is the reality of malpractice risk and limited, one ED is one ED and different EDs have different capacity. How do you incorporate those variabilities, the malpractice risk to the physicians and healthcare teams that are going to be applying these guidelines, and the variability that a recommendation that works in one place may not work well, say in the rural ED with no physician, a PA running the show? How do you incorporate that into the guideline?
So this will fall under the feasibility and acceptability domains when I presented the evidence to decision framework. So that's where you would mention that when you are discussing those factors. and you need to address them because they are important. It seems that in this specific question they are very important. So these may affect the way you make a recommendation. So perhaps your recommendation will say, let's say you're saying you're going to discharge someone with certain characteristics from the ED and arrange for follow-up within 24 hours um, based on some characteristics. So you make that recommendation. You may um, have a second recommendation that speaks about the setting in which there's a mid-level provider or a rural setting or something like that, where you would recommend something different. So you say, so you make it as either a second recommendation or as a bullet in that same recommendation, saying that if you are in a certain setting, that you should do things differently.
And the malpractice risk, do you need a lawyer on the panel writing with you?
No, we usually don't. We've never really had lawyers involved, but you address it that way by giving some qualification for the setting, so that people don't run that risk.
But you, just like you said, the cardiologist would be valuable, or the radiologist with their expertise in that area. Doctors aren't really experts in malpractice law. Wouldn't you need a malpractice expert to give that that weight?
You can do that. I mean, I'm saying typically that's not done, but if you think that's important, you can have your guideline document, once it's produced, reviewed by the society's legal counsel.
Okay.
But that's not a common thing. That's very rarely done.
And there's a question that came in from Stephen Wall. How is the gray literature weighted, given it often does not have enough information for evaluation compared to full peer-reviewed articles?
That's a very good question. And yes, the gray literature, which includes abstracts. So abstracts that are presented in scientific conferences, so it's just an abstract without the manuscript. These also fall under that gray literature, and they do not have enough information to appraise them. So we downweight them. So we either like, you may be in a situation where you have enough studies that you don't care about these other gray literature sources, meaning their impact is small, but sometimes their impact is large. And if their impact is large, that will really reduce your certainty, because now you're very concerned about publication bias. So you have lower certainty, and then your recommendation might be a weaker recommendation because of that.
Okay. Any last minute questions? I want to be respectful of everybody's time. Okay. If not, Hassan, thank you very much for this perspective that you've given us. We videotaped this so that those that weren't on the meeting are going to be able to watch it later. And I'm sure we'll be referring to this again and again in coming months. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Bye-bye.
Thanks.
Thank you.